Good morning, everybody, and welcome. I call to order this special meeting of the Special Committee on Academic Health of the University of Minnesota Board of Regents. That means we're doubly special, I guess. Thank you for those of us who are joining via live stream and video, and to those attending in our boardroom or via Zoom. I want to also welcome our special guest regents today. So in addition to those members of this special committee, we are joined by Regent Kenyanya, thank you very much, Regent Davenport, and Regent Farnsworth will likely come as well. They would normally be in the Audit and Compliance Committee meeting during this meeting, but because it's a special meeting at a special time, they're able to join us, and we certainly appreciate their presence as well. Before we start, I just want to say I'm sure many of us are thinking about yesterday's announcement from Fairview. The special committee has already had an update on the mHealth Fairview on our December agenda, and we will use that time to discuss Fairview's notice then. I know the university has issued a public statement in response to Fairview's announcement. Today's agenda, however, focuses on providing the special committee an opportunity for leadership of our 6 health sciences schools to spend time with us, highlight the work of their schools, and see for us to see how those schools work together. We intentionally wanted to have all 6 schools here presenting because the interprofessional relationship and interconnectedness these schools have serve our state, nation, and world in profound ways. Our time will be structured with each school providing an overview of their work before we turn to discussion. Let me introduce who will be our presenters today, and we're very glad to have their expertise here with us. Tim Beebe, Interim Dean of the School of Public Health, Twin Cities Campus. Connie Delaney, Dean of the School of Nursing, Twin Cities Campus. Keith Mays, Dean of the School of Dentistry, Twin Cities Campus. Laura Molgard, Dean of the College of Veterinary Medicine, Twin Cities Campus. Todd Sorensen, Executive Senior Associate Dean and Acting Dean, College of Pharmacy, Twin Cities Campus. And of course, Jacob Toller, Dean of the Medical School of Twin Cities Campus and Vice President for Clinical Affairs. To kick us off, I'm actually going to turn to Vice President Toller in his role as Senior Leader Liaison to this special committee. Vice President Toller.
Madam Chair, thank you, everyone. Thank you for being here. This is truly a pleasure today to be here together with all the 6 health science schools because I see them as a unique asset we have at the University of Minnesota. And as I mentioned a couple times before, this is one of the only 4 places in the United States that has the honor and privilege hosting all the 6 health science schools. This is the differentiator and distinguishing feature of this university. And I am sure that you will agree with me that the strength of each of the schools bolsters the strength of all of us in the academic health. Since we are going to go in academic alphabetic order, I think School of Dentistry, Dean Mays is going to go first. Madam Chair.
Terrific, thank you. Dean Mays, please begin.
Good morning, everyone. Good morning, Chair Mayoron and members. Please forgive me that I can't be with you physically in the room today. But I'd like to start with just saying I'm really have a big honor and privilege to serve as Dean of School of Dentistry. We've been training dentists and oral health professionals for more than 130 years. We have a combination of degrees that are fairly unique in that we have many specialties, and we have dental therapy, which is we're the only academic school in the country to actually have a program. We're very honored to have received the first CODA accreditation for a dental therapy program just this past August, which is really phenomenal, and a shout out to our dental therapy faculty and the chairperson of that department. As you can see, we educate more than 600 learners in our program. Every year we enroll over 180 students, and we graduate 73% of the dentists who are employed in the state and 68% of the dental therapists who are employed in the state, and approximately 50% of the dental hygiene educators who teach in the state. Next slide. We have a great privilege to serve a large catchment for our patients as well as our students. Being the only dental school between Wisconsin and the Pacific Northwest, we really cover a large territory. And we actually partner with South Dakota, North Dakota with some of their students. And we send students to programs there. But you can also see that we have a tremendous footprint across the state with our outreach clinics. We serve over 120, or see approximately 120 patient encounters every year. And within Moose Tower in the Twin Cities, 55% of patients that we see have public insurance. So we serve as the largest oral health safety net clinic in the state. So we really believe that we're making a huge impact and a great service to the overall health of our patients in the state. We also have in outreach our big emphasis on community engagement. And so we've recently kind of increased that by adding a new position to that division, which allows us to lean more into community engagement and to reach out and do some more direct reach and things like that beyond our mobile dental clinics. So between our dental clinic sites, our outreach clinics, the things that we're going to be doing in the future with the community engagement director and our Moose Tower clinics, I think we're really providing a lot, or in a position to provide a lot of care for patients within the state. Next slide, please. One of the things that I really want to highlight, and I think you spoke to this in the introduction, is the dental school and dentistry in general has been making a statement as of recently, and we say that we're trying to put the mouth back in the body. And so what we mean by that is that oral health is directly related to overall health. And we believe that it's important for an individual's overall health, or oral health, to be taken very seriously. And so from that standpoint, what we've been trying to do is really partner with other schools in interprofessional collaborations. This is just a short list of some things that we're doing. One of the things is our dental hygienists, they have a rotation within the hospital, and they're on the medical service, and they evaluate and assess patients' oral health needs. These are very important evaluations because sometimes individuals have to have clearances before they go into surgery. Sometimes there's undiagnosed disease that could impact their care in the hospital. And so we're there to service them. Many of these individuals were referred to our clinics because of that assessment. So working with each other collaboratively across the health sciences is tremendously important. We've also had programs within our dental school in which pharmacy residents have come in, evaluated patients with our students to make sure that their medications were, didn't have over medication, under-prescribed medication, right dosing, different things like that. So we partner with our pharmacy colleagues as well to do some things. We work with Cook, the VA, and those are things that we've done through a program with AWACA, in which our dentists and dental therapy were in a program to do more things from an interprofessional aspect. And lastly, on this slide, we have had a partnership with, in the past, with dental therapy and a nurse practitioner clinic, which was downtown. And I think that this is a very important model that we should lean into and highlight, because it gives us the opportunity for patients to get their oral health needs and their general medical needs done and treated in one location. And that's a tremendous service to patients who may not be able to take 3 days off to have care done in different places. Next slide, please. And lastly, for my slides, we are a research intensive dental school. We currently are ranked within top 25 at Blue Ridge. We generally hover around the top 15, and we will be back down there very quickly. And so we have really emphasized our research program. We recently redefined our clusters, and you see them listed here on the right. We have 5 core areas that we now are focusing on. And we create a lot of synergy between other colleagues. The IMV Center has been connected with the medical school and the dental school. And so we partner in many, many ways across the aisle, so to say, with our other health professional colleagues. And so we have many, many different types of collaborations. In with one collaboration that came in 2020, when we partnered with pharmacy, nursing, and medicine, created a vaccine course to train learners to give to administer vaccine when COVID virus was during the pandemic time. And so that was a really, really great experience. We had a lot of dental students who participated in that class. I personally participated in that class as a facilitator. And so we do collaborate with each other very directly to improve things. Thank you for the time.
Thank you, Dean Mays. Madam Chair, if I can proceed with the next slide on the medical school side. Thank you for being so anchored in interprofessional practice and interprofessional education, Dean Mays, because that is fundamentally what is the whole medical school about and the whole Office of Academic Clinical Affairs. My charge and my task is to focus on medical school, so that's what I'll do for a moment, starting with the most important asset that we have as a university, which is our students. We have at the moment in this academic year 961 medical students. 81% are from Minnesota. Midwest is the best, and we are very, very proud of the fact that 70% of our graduates actually stay in the state of Minnesota and practice here. We have 789 residents in this academic year. This is the postgraduate education. This is post the 4 years of the initial training. And about half of them, as you can see, practice in our University of Minnesota Medical Center. We, with your benevolence and foresight, will hopefully have your approval at the December 7th meeting so that we can add the third regional campus in St. Cloud. We learned how to do this in Duluth 50 years ago, my predecessors did, but this will add, for the first time in 50 years, graduates of the medical school to the count, and this is going to be 24 medical students and commensurate number of the residencies, which is the postgraduate student, again answering, as always, the request from the state to have better workforce development in the rural sites. Next slide. The UMP, the M physicians, have been a topic of my presentation last time, so I will not spend too much time on this, but I will highlight that we are practicing at 40 plus different locations. We see 1.2 plus million patients every year, and it is the establishment, as you, Chair Wheeler mentioned, our primary partner is Fairview Health, but we partner with just about every single healthcare system in the state of Minnesota. And that is when the land grant mission is really important. Over the last 5 years that we have matured through the definitive agreement, we have been able to show ourselves and others, I hope, that we can do this. We have been awarded Rising Star for quality and safety of clinical care. This is very rare. You have to jump 25 places and get into the top 20 in the single year. We have also been able to advance the market positions of our service lines at the same time. And we have advanced to being #2 hospital in the Twin Cities and #4 in the state of Minnesota. On the right-hand side, you see our accomplishments in NIH funding. This is the first time in several decades that we are top decile medical school, and we achieved that in the very focused management and relentless execution on our strategic plan, and positions us today at the #8 public medical schools and #21 all medical school in the United States and Canada. This is important because it has a ripple effect into the industry, medtech industry, Medtronic, our positions in Medical Alley, our ability to partner nationally. For example, we gotten $70 million grant from the Uniformed Service University, which is the military medical school, and they are working very well with us. Next slide, please. The undergraduate education, that's the first 4 years of the education of a physician. On the left-hand side, you see year 1 and year 2. This is where our students go. And on the right-hand side, you see year 3 and year 4. You see that in both of these graphs, mHealth Fairview and Health Partners and Hennepin are the major players. Next slide, please. The graduate education, which is what every physician needs after she graduates from the medical school to specialize or even to go to primary care, family medicine, and so forth, is depicted here. On the left-hand side, you see the number of the graduate education slots that are sponsored by University of Minnesota. Again, you see that about half is at our primary partner site, mHealth Fairview. And on the right-hand side, these are all the GME slots across the state. Again, Fairview, Hennepin, and Health Partners being the major players. Next slide. The funding is diverse, but clearly this slide, this pie chart should show that the bulk of our funding comes from our clinical practice, and the rest of it is from the grants and contracts. That's the NIH scoring, the Blue Ridge that I mentioned. And this is what positions us well in the cancer and aging, cardiovascular care, primary care, neuroscience, and neurology. So I'll finish with where I started, which is it is about all the 6 health science schools. This is how we connect in the interprofessional education, interprofessional care, and this is how we focus not on a disease. We focus on a patient, on the people. There's a difference between medical knowledge, that's the biology, and medical wisdom, that is the focus on the patient in front of you. And the whole person health is the underlying fundamental of our quest. Madam Chair. And I'll cede the floor to Dean Delaney.
Thank you, Jakob. I welcome the opportunity to talk about the School of Nursing. The School of Nursing has the distinction of being the first school of nursing founded in a university in the United States. It'll be 115 years old next year. Prior to the founding of this school, all schools of nursing existed within health systems. We generally run 1,000 to 1,200 students, which you see on this slide, and over 75% are residents of Minnesota. We make a particular note of the number of trainees that we have at UMMC. Of course, the trainees, as Jakob and others have said, the training occurs across literally all health systems in the state of Minnesota. A couple comments about our degree programs. First, I want to focus on Casey, who you see in this picture. Casey is one of many examples that we can share of a person that went to college, got a degree in anything from the fine arts to computer science, engineering, and they decide they want to come into nursing. So Casey was one of those people. He came into our MN program, which is a 16-month program that takes bachelor's, master's, or PhD prepared people and prepares them to sit for national boards. Casey is from Crookston, Minnesota. He obtained the professional master's. He had in his mind to become a nurse anesthetist. Went back to Crookston to practice, came back to the DNP program, which we were the first DNP program in the nation to offer nurse anesthetists, graduated, went back to Crookston. So he is just a wonderful example of always anchored in the care of the people of the state. What is an interesting fact about nurse anesthetists in the state of Minnesota is that they serve 81 of the 87 counties. They are the primary provider of anesthesia services. Anesthesiologists are primarily focused in the 6-county, you would say, Metro and Rochester community. So the collaboration, again, with the nurse anesthetist and anesthesiologist is quite profound and is extremely important in keeping the critical access hospitals open. I might make a comment that in the state of Minnesota, we also have the phenomenal support of practitioners and midwives, nurse anesthetists having full scope of practice. A couple comments about this school of ours. Additionally, it's the only PhD program in the state of Minnesota where the primary producers of faculty, and of course there is, both in the state of Minnesota across the United States, a large shortage of nursing faculty. We're the second largest doctorate of nursing practice program in the country, produces family nurse practitioners, mental health providers, et cetera. We're ranked 6th in the United States. I want to particularly highlight our wonderful relationship with the University of Minnesota, Rochester. We admit in the neighborhood of 115 to 120 BSN students who do reside on the Rochester campus, and that vibrant relationship is part of also fostering an early admission or guarantee program into our BSN program from the persons admitted to UMR. Our BSN program is ranked 16th in the nation. We have established memorandums of understanding with all of our system campuses. They've been in place for probably 10 years or more. That also includes Rochester. We are second only to Extension on our public engagement footprint as is readily available to all of us. I particularly also want to highlight the program we have for preparing doctorate preparation of the American Indian, Alaskan Native persons. We admitted the largest cohort in the nation this fall into the doctoral program. It was 14 new American Indian, Alaskan Native students, and the trajectory of that program is profound. We are also the home to the Center for Nursing Excellence, Equity and Excellence in the state of Minnesota. And what that means for all of us is that is the state's nursing workforce center, and we are the official voice nationally for nursing workforce centers. So we join 41 other states in sharing and also benefiting from the expertise that they share. And I want to make a comment also about our relationship with St. Cloud State and their relationship with CentraCare and our School of Nursing. Several years ago, thank you, Jakob, for the invitation to explore that relationship. It came to fruition, and we continue committed to expand it and very much support the increasing presence, and if one might say, the medical school presence in St. Cloud. We also have established what are called collaboratories. They're academic practice partnerships. You'll see 9 listed on this slide. On December 1st, we will sign our memorandum of understanding with our 10th one, Hennepin HCMC. So you'll see quite readily that we partner with all the major systems. And we started with mHealth Fairview. That was established in 2015, and 2 years later, we were nationally recognized for all of our collaborative accomplishments, ranging all the way from clinical partnership and expanding clinical opportunities to research and scholarship, best practices, and it's a partnership where we co-determine education, research and scholarship, and other service opportunities that advantage both the University of Minnesota and the systems. When it comes to the major funding sources for the School of Nursing, you'll see it's predominantly tuition and fees. I'll come back to that in a bit. We do have a 16% state appropriation. Sponsored research is 18%. And on the right, you'll see some examples of the research that we focus on. Largely in social determinants of health. We're very health promotion oriented. We're individual families, communities to the nation and international. And I might say on the international level, we share all the way to becoming designated as the first school of nursing in the world that was designated as an NGO. So what happens here actually has this funnel of influencing healthcare around the world. We have a particular focus on the children and the women. We also focus on nature-based therapies, that is an example of mental health. The school, or the Center for Spirituality and Healing, is housed within the School of Nursing. We celebrate that partnership. Public health data and data science are a key core of our School of Nursing. And the communities that are, I'm going to say, not always well served are a particular focus of the school. On this slide, I want to highlight, so how do we run things in terms of finances? So all of our academic programs are supported through tuition and fees. That's a strain right now. So we are running at a deficit. We're choosing to use our reserves to do two things: bring on more faculty, and that usually takes anywhere from 6 to 10 years for the true productivity to happen in all of the service sectors. When I mentioned the collaboratories, there's no money exchange between the collaboratories. Two comments about that. If there is an initiative that requires actual financial resources, we negotiate it at the time. For example, Mayo Clinic. We have a wonderful scholarship research initiative of researchers here and at Mayo Clinic working together. Another example from Mayo Clinic that relates to academic programs is we were approached to partner with them to expand nurse midwifery capacity. So an additional comment about that. We have phenomenal space and applicants to accept more midwifery students, nurse anesthetist students. We probably get 300 to 400 applications for 15 slots. So I'm mentioning how we're poised to grow. And that relates to the fourth bullet. I'll come back to the second and third one. Our significant barrier for growth is access to clinical sites. We can grow the BSN in Rochester particularly. We can grow the MN with our partnership with the other campuses. We can grow the DNP, and our PhD program, which is a key supplier, again, of faculty, has been growing significantly. All of our research is supported by grants, and the infrastructure is supported by the indirect funds that those grants generate. We're beginning to establish some funding through our UMF. The clinical engagement, we have over 1,000 clinical placements per year. You note most of those are in Minnesota. None of the students receive any payment for their clinical engagement, and none of our preceptors receive payment for preceptoring students. Our practitioner trainees, who are part of the systems, as Jakob pointed out, are counted in the system that relates to the MERC funding. So a few final comments. You might wonder how the school, again, in the full boldness, works with our other schools and colleges. As Keith pointed out in the very first presentation, we're intimately involved with dentistry, we're intimately involved with pharmacy. We work very closely with medicine and dental, and we work with vet med. So our research. Public health. Oops, sorry, Tim. It was in my head, it didn't come out.
I'm like right here.
And you're one of our key partners. So that includes both academic and our research. Sometimes we take the lead, sometimes we're a partner, and it's negotiated depending on what the agenda is. And it's always focused on, as you said, Jacob, it's focused on the needs of the people of Minnesota. My last quick comment is that I had mentioned that we are operating at a deficit. And I mentioned that our increased enrollment, which we are fully poised to do, we have no problem hiring faculty. Faculty come to us regularly. And so we are turning away hundreds every year. I gave some examples with the nurse anesthetist program for the BSN program. We have in the neighborhood of 1,000 applications, and we accept about 135. So with that, I'll leave those thoughts for your deliberation and look forward to questions later. Thank you.
Good morning. Thank you for the opportunity to be here this morning and represent the College of Pharmacy, and particularly to represent Dean Wellich. Dean Wellich has found a need to take a medical leave, and I have been serving as the acting dean for the last month while she is preparing to return to the College of Pharmacy very shortly. As we start off, the picture of the School of Pharmacy in terms of our students and our graduates, a couple of things behind the numbers that I think are important to share. First of all, within the last year, we are not only a pharmacy program, the occupational therapy program and the medical laboratory sciences programs have become part of the College of Pharmacy, and we're in the midst of the integration of those programs into the college as a whole. We are proud of the fact that we are the number 3 ranked College of Pharmacy in the country of 143 schools of pharmacy across the country. We are the only College of Pharmacy in the state. That's become quite rare with 143 pharmacy schools. So for a state of our size to be the only school of pharmacy in the state is somewhat unique. The degree programs that are listed on the right-hand side there are diverse. Of course, the PharmD program, we have master's programs in multiple areas, disciplines. Medical laboratory sciences is a bachelor's program as well as a master's program. We have 4 different PhD programs, the Doctor of Occupational Therapy program. In addition to that, I would mention that we have dual degree programs, PharmD MPH program, PharmD MBA, PharmD Health Informatics programs are important parts, and we are seeing an increasing number of our students in the PharmD program pursuing dual degrees. The other thing I would note is that we operate on all 3 campuses. We've been on the Duluth campus for about 20 years now, and have had a strong pharmacy program on the Duluth campus. With the addition of occupational therapy into the College of Pharmacy, we are now also, in addition to the training program that we had, experiential education programs in Rochester, we now have a program that has faculty and students based in the Rochester campus through occupational therapy. We are very proud of the fact that we serve the whole state, of course, from a workforce standpoint, and that starts with the partnerships that we create across the state. So this gives you a picture of all the different places that we work with. This includes educational programs, clinical training, it includes outreach, and it includes research. So it has been a long history, a point of pride for the College of Pharmacy of how we engage with communities across the state, not just for clinical training, but really exploring the medication use and healthcare issues across the state, and really supporting interprofessional practice across the state. Some of the things that those partnerships represent are described here. Again, not listing all of the clinical training experiences, but really focusing on challenges that we face in communities across the state that relate to medication use, and how, as a College of Pharmacy and as a university, we're engaged with those communities, we're in partnership with those communities. Access and quality of care, I mean, I could speak on each one of these bullets of the details behind each of them, but we're seeing reduced access to pharmacy services. We have built programs that help with the development of quality improvement initiatives in this space. Health equity has become something that we are specifically focused on, and doing that through our graduate programs, as well as some of the clinical partnerships that we create to expose students to the types of experiences that underserved communities are experiencing. And you see that in the latter half of this slide. We've been very intentional about focusing on rural Minnesota and collaborations, workforce development in rural communities. And the Federally Qualified Urban Healthcare Network, that has become an important partner for us for clinical service, for clinical training, as well as for research around health equity and health outcomes associated with medication use. I would also point out that as we've gone through a long period, too long of a period, with concerns around substance use disorder, that has been another area of focus of the school related to particularly with tribal communities, as well as the rural communities in general. And we're proud of the fact that we have a number of faculty who have developed very strong relationships with those communities, trusting relationships, and really in a strong community engaged way. So it is not the university coming in and trying to help solve the problem, but to work with the communities to understand the problem and co-develop the solutions. Our funding distribution is pictured here, and as you can see that we are largely tuition and grants and contracts Over half of our funding comes from those sources. We are proud of the fact that we have a healthy endowment and endowed funds within the College of Pharmacy that has been an important part of us navigating some of the financial challenges we've experienced, similar to what Dean Delaney described with the School of Nursing, that we are also in a position where revenues are not keeping pace with some of our expenses as we continue to right-size the organization. But in the face of that, we have also reduced tuition as a function of creating accessibility for our students. So we've been navigating that, and one of the things, reserves as well as our endowments, has allowed us to be able to do that successfully. If we look over on our research areas, some of them have already been referenced, but in addition to interprofessional education activities with each of the other 5 schools, this is a key area where we have a number of partnerships and collaborations across each of the schools. In the area of neuroscience, cancer, we're a strong participant in the Cancer Center. We've been working collaboratively across different schools and with mHealth Fairview on the creation of pharmacogenomics programs that leverage that new technology to help prevent medication-related issues when we can predict them based on genetic makeup. I would also highlight where it describes solutions to major global problems. An important example there is our partnership with the School of Public Health and really looking at drug security issues from manufacturing all the way through to reaching the patient. And there is a lot of risk that's in play right now regarding the drug security pipeline. And that's been a significant area that I think we've really been a national and international leader on through the partnership with CIDRAP. So we'd like to pride ourselves in the fact that we as a College of Pharmacy take a role in and a responsibility for the entire life cycle of pharmaceuticals, from the point of drug discovery to clinical application to policy, economics, and ultimately for patient outcomes. Our faculty involved in that entire sequence of the patient experience associated with medication use. So thank you.
Thank you.
Hello, everybody. Thank you for inviting me today to talk about the School of Public Health. I am Tim Beebe, and I have been interim dean almost 2 years. I will be stepping down at the end of the year, where we'll welcome our brand new dean, I'm Melinda Pettigrew from Yale School of Public Health. I want to thank Provost Croson for picking someone real nice for us. And so we're very happy to make that transition. I'm sure the school is happy to have me gone. So thank you for today. I have to say that these last 2 years have been the pinnacle of my career. I think it's been the highlight of my life to serve in a leadership role for this wonderful School of Public Health. I am just so excited from this perch to see the entirety of the school and all it brings to the state. So I'm not going to really follow the slides. I don't really do that. I'll use them to underscore points I want to make. But I want to kind of give you a sense of the school first. So we were established in 1944 with an endowment from Drs. Will and Charlie Mayo, who had the foresight to see public health as an important feature of our collective health. And I have, when I worked at Mayo Clinic for 13 years, and we all get a book of aphorisms from Will and Charlie. Like Regent Johnson probably has one on her bookshelf. One of the aphorisms from Will Mayo says, the aim of medicine is to treat disease and prolong life. The ideal of medicine is to eliminate the role of the physician. So that's a very cruel position, but it's also a very public health position. Another fun fact is that public health education started here at the University of Minnesota almost 150 years ago with Charles Hewitt, who was a Civil War surgeon, was the first professor in public health in the country. And so it all started here. We are in the top 5% of public schools of public health, and there are 230 of them. More added every day. There was 2 added last week. So the competition is stiff. We are the number 6 public school of public health, and we're 12th overall according to the U.S. News and World Report. So we are the only school of public health in Minnesota, and we take that obligation and role very seriously. So let's go to this one here. So you can see, we're a research powerhouse. The Pac-Man slice of the pie here is all research. We're very proud of the fact that we have the 3rd highest research portfolio in the university and the 2nd highest NIH funding portfolio in the university. We have the highest per faculty funding in the university with $1.1 million on average per faculty member in terms of funding. So we're a school of firsts. I mean, Dean Delaney laid out a number of firsts that the nursing school laid out, and we are also characterized by that. Who has heard of the Mediterranean diet? Who likes it? Well, you're welcome, because we conducted the first multi-country epidemiologic study that led to the Mediterranean diet. We are the go-to for NIH for clinical trials of huge import, the Ebola outbreak in 2014 and most recently COVID outbreak. We also have a biostats department that is innovative clinical trial design and adaptive designs that allow as much rigor as a regular randomized clinical trial, but done in a very fast pace. We have experts that's developed new treatment protocols for persons with HIV that have saved millions of lives. We're the first to establish the connection between e-cigarettes and cancer. And who's heard of the rural broadband access legislation? Our research undergirded that. Who's heard of the Medicaid payment legislation for doula care? So our work has addressed equity and impact. We tried ourselves, per our land-grant mission, to translate our research into policy and practice. And so if you look on the right-hand side of this, there are notable areas of research. We have a large book of work in healthcare delivery and improving patient outcomes. We have a very strong collaboration with Oaxaca Medical School. Many thanks to Dean Tolar for helping us establish our Center for Learning Health System Sciences, which is unique in the country because it is a collaboration between public health and medicine. We have intersectionality with nursing and pharmacy on that as well. We've been meeting, we really like each other a lot, and I'm going to miss you all because you'll never see me again. But we've talked about what are our collective interests, and kind of organically and inclusive, we came up with areas where we all kind of work in the same space. We all have a book of work and interest in rural health that binds us, and we can explore more intersectionality along those lines. Aging is another area that binds us, all the schools together, as well as health equity. We all are committed to that and want to work more in that area together. I think the potential in those areas are boundless. So let me pop back up to this one. So we're an education powerhouse too. So, and that's not just hyperbole. We have 20-degree programs with any given time, 1,000 students that we train, and they go out to the world and impact public health practice across the world, and also serve the state quite well. So here's a fun fact. We train about 2/3 of all the public health professionals in the state, and if you add the public health training that nurses, pharmacists, veterinarians get, it's probably higher than that. So we're pretty cool. So we have dual degrees. It was mentioned in pharmacy, we have MD, MPHs, DDS, in every discipline. We have Regents approved dual degrees in public health in these areas. So that's something that we can leverage more. I think vet med is probably the most popular, but I think there's a lot more that we can do along those lines. So this last semester, we just started our first undergrad program in public health based on indexed off the secular trend and what the public health system needs in terms of training. Bachelor's degrees just eclipse MPHs in terms of degrees that are desired in governmental public health. So we're standing that up. We're very excited. The first cohort of 15 are just wonderful students. And we're very excited. I can't wait to start teaching them once I shed the dean role. So we're expanding upon our very popular undergraduate minor in that, where it's the second most popular minor on campus with 400 to 500 students enrolled at any given time in that minor. And so that's, you can see that there's a large demand on that. looking at the top of this, we're very proud of our second ranked Master's Healthcare Administration. We're the first in the nation to stand one of those up. You can see here that 34% of the alumni stay in Minnesota, and about a third are also in our executive program are physicians. And so, and you can see if you look on the right-hand column and you look at the pictures that we have, a number of them have taken significant leadership roles within healthcare delivery systems in Minnesota as well. So we're very proud of the impact that we've had in that space. We have the number 9 ranked biostatistics program in the country, and we're the first to start an epidemiology PhD degree, and the first MPH in maternal child health, and the latter was just rated the most impactful by Bloomberg News. So we just completed a 6-month-long brand strategy, doing focus groups and surveys and the like, and to see how we differentiate ourselves, because it is very competitive. And we, for the first time in 30 years, we slipped out of the top 10. And so we want to know, how do we differentiate ourselves? And it was clear from our work that what differentiates us is our commitment to achievement. We have nationally and internationally ranked physicians, faculty that are available to students. Our commitment to community. We do translate our research into policy and practice and index our work off of the needs of the community. And we have a strong commitment to health equity, social justice, and anti-racism. We're very proud of our strategic plan for anti-racism. And so that's our school. We're very happy to answer any questions on what we've done. I just want to highlight the fact that we have a lot going on across the schools. We like each other. I'm sure you'll like Melinda more. At least she'll probably remember you. Anyway, so thank you, and I'll hand it over to my colleague, Dean Mulgard.
Thank you.
Great, thank you.
Yeah, you can do it for me. Thanks, Connie. So one more. All right. So thanks for this opportunity to share a few thoughts about the College of Veterinary Medicine. So we are the only College of Veterinary Medicine in the state. There are only 33, although it is changing on a daily basis, colleges of veterinary medicine in the U.S. So we serve not just the state, but to some degree the upper rural Midwest. And we train the next generation of veterinarians, veterinary specialists, and biomedical scientists to protect the health of animals, people, and the environment we share. People don't often think about that. When people think about veterinarians, they think about dogs and cats, or they might think about farm animals. But veterinarians take an oath to protect the health of animals and the public health, as well as environmental health. But there's a critical workforce shortage of veterinarians and a maldistribution of veterinarians across the state and across the country. One of the statistics that I learned within the last year is that there's also been a doubling of the clinical faculty workforce shortage. Mm-hmm. So over the last decade, the veterinary clinical faculty workforce shortage has doubled. And that's only going to be exacerbated as now a few more veterinary schools come on board, making it even harder to train more veterinarians to meet that workforce shortage. So this infographic, to some extent, underestimates the number of veterinarians that come back to practice in the state, because many veterinarians do go on for advanced training to do an internship or a residency, and so many will come back. We estimate that about 70% of the state's veterinarians were trained at the University of Minnesota. So again, we all know that companion animals impact the health of people in positive ways, both emotionally and physically. So I'm not going to spend any time on that. I'll be talking about some of the ways that veterinarians impact the lives of animals, people, and the environment we share that you might not know about. Next slide. So we are one of the largest academic veterinary medical programs in the country. In all parts of the mission: education, advancement of new knowledge, and providing compassionate care. And we touch the entire state as we do that through a variety of ways. One that we talked about with some of the new regents not that long ago was VetFast. We recruit students who are interested in food animal practice from our system campuses. And we've been able to, therefore, maintain a real edge with food animal veterinary, graduating food animal veterinarians, meaning veterinarians who are going to go on to serve production animal veterinary medicine, animals that are intended to enter the food supply. Also, our students go out into externships. Those are placements during their clinical year. Veterinary medicine is a little bit like undergraduate medical education in that students have already done a 4-year undergraduate program, and then they come to veterinary school for 4 more years. And at the end of that program, they go out into clinical placements, and they do that throughout the state. Also, our veterinary diagnostic laboratory very much serves the entire state. The veterinary diagnostic lab is the state's animal health laboratory, much the way that the Minnesota Department of Health is the state's human health laboratory. The universities has the animal's state animal health laboratory, the VDL. So protecting animal health also protects human health in a number of ways that I'll touch on briefly here today. So as we all know too well from the COVID-19 pandemic, zoonotic diseases are diseases that impact animals and humans. They may be diseases that are spread from animals to people or people to animals, but it is evidence that animal and human health is closely intertwined. In fact, it was a veterinarian who first identified West Nile virus, which is a mosquito-borne virus that is dangerous to people and to birds, as well as other animals. So, in other words, the critical workforce shortage of veterinarians threatens human health as well as animal health. Next slide. Comparative medicine is a unique opportunity here at the University of Minnesota within our health sciences. And we use that term in veterinary medicine to talk about how we can use spontaneously occurring animal diseases to better understand human diseases. So you may have had pets with cancer or known of people who have pets with cancer, but about 1 out of every 3 of our pets will develop cancer in their lifetime. Another example might be cardiology. We routinely implant pacemakers in animals, just as human cardiologists do in people. So through these spontaneously developing animal health conditions, we are able to study diseases that also impact people, and that helps us learn more about these diseases to develop new therapies and diagnostic techniques. So for example, our brain cancer clinical scientists work closely with colleagues at the Masonic Cancer Center and developed groundbreaking treatment called CD200 checkpoint inhibitor in dogs that is now in human clinical trials. So this is a treatment for brain cancer in people that was first studied in dogs with spontaneously occurring brain tumors. So this is an example of how the university's breadth and quality is an asset that we should not overlook. But when the state underinvests in this asset, we all stand to lose. Next slide. So how does Minnesota benefit from a strong, highly ranked College of Veterinary Medicine? As I've mentioned, in the 21st century, a multitude of diseases are on the brink of crossing the barrier between animal and human medicine. SARS-CoV-2 was one of them. There was a recent article just last week in the School of Public Health's CIDRAP website, the Center for Infectious Disease Response and Preparedness website, that was asking important questions about the relationship between prion diseases and other protein misfolding diseases like Parkinson's, Alzheimer's, and ALS. And in all of these cases, our faculty, our collective faculty, are on the front lines working to understand and keep all of us safe from these emerging diseases. Peter Larson, one of our veterinary school faculty, was interviewed in that particular article. So from highly pathogenic avian influenza that we've all been hearing a lot about seasonally, and threats of African swine fever, Minnesota's multi-billion-dollar agricultural economy is at risk. Veterinarians and our Minnesota Diagnostic Laboratory are protecting the health of people, animals, and a safe food supply that we too often take for granted. So I hope that I've touched on some important pieces of how veterinary medicine fits into this puzzle in ways that people often might scratch their head about. To circle back to some of the points that others have made, the flat funding that the colleges have experienced over many years and have forced us to first raise tuition, but then hold tuition flat because tuition had become too high. The cost of a health professions education is necessarily high because of the way we have to train health professionals, but the costs had become unsustainable for the graduates. So that requires us to make cuts elsewhere. And that risks us losing talented faculty to other institutions, or in the case of some of our schools, to private practice, where they can work fewer hours, spend more time on their research, which seems paradoxical that they can spend more time on their research in private practice than in an academic institution, and have appropriate administrative support that we've had to cut. So with the healthcare workforce shortages that are faced across the health professions, it's a shame that we have to turn away qualified applicants that we've all described that we have. In the case of veterinary medicine, we have 1,500 applicants for 125 seats. But without investments that other states are making, we can't advance. So thank you.
Great. I just want to thank you profoundly for not only these presentations, which, boy, you packed a lot into succinct presentations with a lot of materials when we know that what you do is very, very deep. So I want to thank you for that, but I want to thank you for your leadership more, and that of your teams more profoundly, because obviously the impact you have on the health and well-being of the state of Minnesota is profound. You know, and then the innovation is globally reached, everything from the origins of pacemaker to childhood cancer to pharmacogenomics to social determinants of health to comparative research is pretty profound. So we know we have a tremendous asset here, and what we want to do is try to do all to support it in the best way. I'll start with a question, then I'll turn to some of my colleagues, but one of the gems we have here is the ability to do interprofessional collaboration, as you've talked about, and that's why we wanted to have you all here today at the same time. One of 4 schools in the country, as Dean Toller mentioned, going forward. When I was here, and I'm a product of the med school, you know, basically we were all siloed off, and then they threw us together when we were out in practice. So you've done tremendous work to try to connect these roles and even extend them appropriately to public health and to veterinary medicine as well. If we were to, if an investment were made to advance interprofessional education, where best would we place that?
In the School of Public Health.
Your expected response.
I don't want to disappoint.
I suspect strongly, I'm on the task force, as is Dean Delaney, as is Dean Toller. I suspect strongly one of the recommendations is going to be to use our assets to advance interprofessional education. So trying to get a little bit more knowledge from that based on your replies.
We may all have different answers. Since we didn't prepare that answer, I would say in the community. When we are able to get our learners out into authentic community settings. So for example, we've been talking with Brian Sick about getting our students, our veterinary students, into the Phillips Neighborhood Clinic. maybe not in the clinic, but adjacent to the clinic, to be able to provide interprofessional care to with other health professions learners. When we're able to put learners in authentic settings where the health professions can work together. And there are models in other states like Washington, the University of Washington, that do that, even with veterinary students providing. And when we are able to provide care to pets of people who are underserved, those people come in and get their own care where they might not have otherwise. That's one answer from one fairly niche direction.
Great, thank you, Dean Mulgard. Yeah.
I would share 3 additional comments in addition to the key priority of public health, which we very much resonate on that, Kim, and as Laura mentioned, and that includes from all of us. You heard the number of students that we're turning away. And so as we can grow and meet the shortage, there are shortages in all areas, as we can invest and serve those students, we bring them into an interprofessional environment. The second is we, by very nature, talk and engage in interprofessionality. There were many examples shared, whether it's our academic programs, our research, we have joint degrees, we share faculty, the list goes on among all of our schools. And my third comment is we are one of the interprofessional leaders in the nation. We were early in this defining true interprofessional. And just a quick example, there's a required experience of all of our students as they enter to engage in an interprofessional structured experience. So these students come together to learn about each other at the beginning. And there are many ramifications and extensions of that experience. All of our faculty help teach that. Those would be my quick 3 additional comments.
That's great, thank you. Thank you, Dean Delaney.
Dean Mays.
Oh, Dean
Well,
Hayes, thank you.
I would add that Brian Sick, I think, is a good connection. We've talked a lot about this. We've talked about an opportunity that I think exists at the Wilmer Clinic. Our dental students rotate out there, our hygiene students rotate out there, and there are medical students who rotate as well. We've had a relationship with OBGYN there where we did prenatal just before the birth, connected with the mother to try to connect with the child when the child was born. I think that these clinics are a great opportunity to lean into and to help shape those things. I think that it would be very good if you're leaning towards things that there's some incentive for these partnerships. Just speaking candidly, a lot of my colleagues will continue to try to function as they currently do because there's no real design or incentive for them to change. And so I think if we can shape some of these things, we can continue to guide the efforts that we've already started begun into the direction that we ultimately really want to go into. I think it will be a great benefit for improving population health and reducing cost of care.
Great, thank you so much, Dean Mays. Yeah.
I would add, building on what Dean Mulgard said, I agree with the moving to the community. An additional thought on that is, as we move from interprofessional education to interprofessional practice, and that we have been a pioneer as a university in interprofessional education, but we still haven't reached full interprofessional practice across the state. And when we have to move from co-location to collaboration to interdependence, when we reach the level of interdependence across the disciplines, then we will have achieved the ultimate goal. That is getting closer when we are working in the same physical spaces, in the same employment spaces in some ways, health systems, but not all healthcare practitioners are in that shared space. So where we see the challenges of interprofessional practice are when We are not on a common electronic health record when we're located in different entities. And I think that's where I would suggest we consider an investment, is how do we not only advance interprofessional education, but advance interprofessional practice within the state.
Great. Thank you, Acting Dean Sorensen. I'll leave one more comment to Dean Toller, and then I'll turn it to my other regents who have lots of questions. So,
Just very briefly, Chair Wheeler, thank you. Excellent comments, co-location, collaboration, interdependence, of course, yes. In addition to seeing this from the perspective of each school that we have, we also house the National Center for Interprofessional Education. This is one of the leading centers nationally, very visible. And Provost Krausen and I, collaborate across the Health Science Education Building. And again, Brian Sick, who has been mentioned, is one of the leaders there. Thank you,
great.
Chair.
Thank you. I'll turn to Regent Turner.
Thank you, Chair Wheeler. We had the privilege, a few of us regents, to meet with some of you not too long ago. And I don't know if you recall, but I was kind of asking for little talking points that we could use up at the legislature. And I just want you to know that right after that at Morris University for the Chancellor inaugural event, I ran into, I met the Republican legislator up there who just happens to be a farmer. And we were riding on the bus and going around and visiting all the research sites. And darned if I didn't use the old concept that we have 1,500 applicants every year for veterinarian and only able to do 120 spots.
Thank you.
And that, you could just see that resonated with him. Him and his wife sitting there as farmers. That resonated. And that, I wanted to come back and tell you that because that's what I'm talking about. And I hear that all of you, well, I know, I'm a nurse. We all have the same problem. But just using those kind of figures and translating into the workforce shortage, and then strategically going legislator by legislator to figure out which one there is going to hit them, made a difference. I could see it in his eyes. I could see it there, like, because that affects what he does for a living.
Thank you, Regent Turner.
Thank you. I'll go to Regent Hipsch.
Thanks, Chair. First of all, I want to just say how impressed I am with all of you and impressed with the medical system of Minnesota. I think it's really, really important. So the last line in our mission statement is, we are unified in our drive to serve Minnesota, which I think we can all resonate to. But one of the things I saw in the numbers is the direct correlation between Minnesota residents and number of people employed in Minnesota. The higher the number of Minnesota residents in our schools, the more people stay in Minnesota. So that's good to serve Minnesota. So I'd like to see that high. But then I also heard 5 out of 6 of you, I think, say that we're really facing severe budgetary challenges. So then when I look at in-state versus out-of-state tuition, like I think in public health, I don't want to pick on public health, but I think in-state is or out-of-state is twice as high as in-state in public health. And so are we accidentally, to meet our budgets, going to out-of-state tuition as a way to solve our financial problems, but that's not serving the state of Minnesota? That's what I'm scared of. And I think that the long-term cost of that is high. And Regent Turner talked about vet school. I mean, in a couple of days, we're going to be celebrating Thanksgiving, which a lot of us are going to be eating turkey. We're the #1 turkey producing state, which we can't do without veterinarians, but also we can't do without a vet school that has research because of things like bird flu and, you mentioned other diseases, West Nile virus. That's the first thing. The second thing is, in my town, there's a milk plant that's invested in a dog food, pet food plant that invested about $1 billion in the last 8 years or so, and they produce about 1,200 jobs. We process 5 million pounds of milk, making 500,000 pounds of cheese every single day out of that plant. Without veterinarians, we can't solve that problem because we need dairy farms, right? And we can't solve, the people aren't going to have pets if they can't have veterinarians, because that's pretty integral to what they're trying to do. And so I know there's a huge shortage everywhere, but how do we get more Minnesota, and then now that we're playing Wisconsin this weekend on reciprocity, let's talk about that. Wisconsin pays less for tuition than our own people pay in Minnesota. So we're giving a break to Wisconsin to come and study here over our Minnesota kids. That doesn't serve Minnesota well either. So these are a lot of big issues that I'm looking at diving into the numbers more and trying to figure out how do we solve it from a numbers point of view. So thank you for that. Anyone who wants to comment can.
I'm sure each of us has unique context to each of the scenarios, and so I can only speak to what we've seen in pharmacy. But in our case, we do not have the same challenge that veterinary medicine has in terms of the number of applicants to the number of seats. We have fewer applicants than we would like to see, and so the recruitment issue is an issue, and part of it is a choice of which, first of all, do you even want to go into healthcare? Second of all, once you choose to go into healthcare, is pharmacy where you want to go? So we did reduce tuition for outstate, our outstate tuition rate. And part of the reason is we have seen, because of the progressive healthcare environment in Minnesota, when we import a student from another state to become a student at the University of Minnesota, very often they stay in Minnesota. And so the idea of when we can't necessarily recruit as many Minnesotans into our program as we might desire, having students come here and have an affordable outstate tuition is actually, in many cases, supporting our workforce needs in the state. Because they come here, they experience the lifestyle that we have in Minnesota, they experience things, at least in my discipline, that they can't find in other parts of the country. It's a very attractive place to practice, I think, for a lot of healthcare professionals, and we've seen it specifically in our case.
Okay, I'm going to turn to Regent Verhalen.
Good morning. Sorry about that. Can you hear me okay?
We can, thank you.
Great. Thank you so much to our presenters today. Every time I go through your materials and then today's presentation, I glean something new. One of the challenges, though, is there's so much information there. And so what I would ask each of you to think about, and I know I'm putting you all on the spot, so my apologies, but we as decision makers are coming at these presentations trying to find out what is most important as we make decisions that impact each of your schools, our students, the communities, et cetera. But also to Regent Wheeler's point, Chair Wheeler's point at the beginning, there are other decision makers who are interested in this as well for a variety of reasons. So I would ask each of you, what do you want us to take away as the most important thing as we're making decisions that could impact your schools and your students and your communities going forward for the university? And I realize it's a very large question to put on all of you at this moment.
I'll go. So one of the things that, thank you for that question. It is a big question, but it's something that really has been vexing public health forever, is this cycle of neglect, panic, and repeat. And where we freak out when there's a pandemic and try to scramble and craft a public health system that intersects with the healthcare delivery system that meets the needs of the populace. And then we kind of instantly forget about it, defund, and move forward. And so I guess if you remember that large Pac-Man slice of the pie of our funding, 75% of our funding's research grant funded. So it was we had to drop all that research to work with the Department of Health and the healthcare delivery systems to meet the needs of the Minnesota residents during the pandemic. There was no white space to be facile and nimble to respond to those things. Moreover, we're not taking this opportunity in between pandemics to craft a public health system that is more responsive. If you want a good roadmap of what we're going to be seeing, read the Great Influenza. There was a panic to pull things together, neglect, and it happened again. So that's one of the biggest challenges. How do we come up with the funding model that allows us to, during times of crisis, intersect in a systems-based participatory model with systems like healthcare delivery systems, government systems, as well as communities, to see how do we equitably distribute therapeutics, vaccines, all those sorts of things, all the clinical trials that we did on vaccines and therapeutics were basically done on the backs of others who are otherwise subscribed. So 90% of our funding in our school comes from tuition and research, and it doesn't allow us to be that sort of academic health department that intersects with the Department of Health and healthcare delivery systems. Be prepared. So we should be thought leaders. We have one of the top schools of public health. We have one of the most innovative departments of health. We have one of the most innovative healthcare delivery systems writ large. We should be leading the way. And yet I feel like we're not going to be prepared for the next potentially more impactful pandemic, not to harsh everybody out, but that's what I would say from a public health perspective.
So my comment related to that, in addition to what's been said, is the ability, we have a desperate shortage of a variety of healthcare providers in the state. We know about nursing. We need 4,000 in the next 6 years beyond what we're graduating. This is the most dire situation I've ever lived in. And we're sitting in an environment of interprofessional is how we live, teach, do research, and how we engage in the practice environment. At an umbrella level, when one looks across these presentations, we have the structure, we have the passion and common purpose in all of these schools, and there are others that we didn't mention, like computer science and engineering and others. And most of us are turning away students, just hundreds. And when you add us up, we're turning away thousands. Majority of those are Minnesota people. So the desire is there. So when I look at the umbrella of this, and then to tag on where you were, Tim, the built-in attention and expertise related to the whole continuum of health promotion, prevention, as well as acute care, and the full continuum toward people transitioning is built in to the assets that this university holds. So my comment is celebrating the breadth of the umbrella that's sitting right here and enable us to welcome and serve the students that are coming to our door that then engage in the breadth of our health system, including the rebuild, I'm going to say, but it might be an early build of a phenomenal public health system for this state.
Thank you.
I can answer that question as well too. I think one of the things for dentistry is really don't forget oral health. Oftentimes for a lot of reasons, we're kind of an add-on. Even if you think about our insurance model in the U.S., dentistry's reimbursement is much lower than other professions. And so it gives us all kind of this optionality kind of piece. And so it's important that we, as educators, rebuild that and to continue to lean into dismantling that. And so I would really make sure that we keep oral health first in this conversation and always at the table. We have to remember situations like Diamante Driver, a young kid in Maryland in 2007, I think it was, who died because of an abscess from a tooth infection. And so it is really, really important that we make sure our population's oral health is up to date and well maintained. In previous years, and still now to some extent, in the military, dentistry is a part of the readiness. You could not have someone going on the battlefield and having a tooth problem. And so it is really important. Individuals are not comfortable in school. They're not going to learn very well. So we have to really make sure that oral health is a continued part of the conversation and really leaned into and looked at. I would also kind of add a little bit, if you look at our model financially, we're one of the institutions similar to Vet Med who have both education and clinics. And our clinics, as I stated, 55% are public insurance patients. So it is not a big driver. And so we lean very heavily on student tuition. And so any funding that can shift that, because if we can reduce the cost to students, then when they graduate, they have options of where they want to practice based upon what they want to do and not what their debt drives them to do. So those are the things that I would add and use to answer your question.
Thank you for those answers. We're sitting with just a little less than 10 minutes, and I want to get to some other questions too, but boy, we're learning a lot. I'm going to go to our board chair and Regent Mayron.
Thank you, Regent Wheeler. As I look at the materials that each of you prepared, I am struck with how dependent you are, and to varying degrees, on sources of income other than tuition and other than state appropriations. And those other sources can be as a result of research and grants, or they can be due to your clinical services. And it seems to me that as we go forward, we all collectively need to think about what we can do to enhance your ability to bring in those alternative sources, whether it be through clinical services or research, as opposed to relying on tuition or state appropriation, where we have very little movement, is the way I see it, at least based on, if the past is the best predictor of the future, we can't rely on that. So I do think anything in your collective wisdom that you can bring to us to say, this is what would help to enhance our ability to generate more research, get more grants, or enhance our clinical services, the fees we receive, I think would be very helpful for us as a board. And I wasn't expecting you to collect everything. It's just,
So true, but
I'm just so struck with how dependent, we can't rely on tuition and we can't rely on appropriation to move this forward.
Chair Mayor, and if I could respond, I think it maybe ties into the last question and your question is, I think that's what maybe my overarching synthesis statement would be, is a recognition of the board of how different health sciences are than the rest of the university from a budgetary point of view, from a mission point of view. From a mission point of view and a budget point of view, our budget portfolios, while different, the School of Public Health is so different than the colleges of veterinary medicines, but that we are different. We are not like the rest of the university. And I don't mean that we are more important. I mean, we are different. We are unique. We have a lot of things in common with each other. And we have unique challenges that set us apart from the university, that require different approaches that we talk about together, and it is helpful for us to have that recognition from you that this isn't a one-size-fits-all with the College of Liberal Arts or the College of Design.
Just as a follow-up, I was so struck, particularly when I looked at the medical school and saw that only 3% of its revenue or funding sources come from tuition. How the good news is how successful you've been in generating through clinical services fees and through the research. But the bad news is, that's the good news, and it's what are we going to do to enhance it, because raising tuition isn't going to be the way to go, or expecting it to come through state appropriations.
And the impact that has on the kind of faculty that we hire, et cetera, and how different that makes us than non-health sciences parts of the university. Thank you.
Great, thank you. Thank you so much. I'm going to turn to Regent Farnsworth.
Thank you, Chair Wheeler, and I'll just be really brief. Thanks for having us audit folks over here today. This was really, really interesting to me. I learned a lot. I feel, out of all the presentations in different committees on the board that I've been in since being on the board, this one really stands out to me because I liked that you all, kind of followed similar formats to a degree, especially when it comes to the funding sources slide. But then also, of course, got into some discussion about all the differences and the nuances between the colleges. So as someone who doesn't bring a lot of personal experience, both either personally or professionally, to the areas of health sciences today was really beneficial for my future governance training and lens as we come to some decisions, not only just in budget, but also many things that were highlighted today when it comes to workforce shortages, faculty workforce shortage, shortage of clinical placements and nursing. I wrote down a lot of highlights, and then I appreciate Regent Verhaalen's question, because I think that next round of conversation also got some really helpful highlights as well that I will take away from this. So I guess when you go last, a lot of other things I was going to say were already very wisely covered by colleagues, but just want to thank whoever had the vision to pull this together today and offer the experience to all of us. And particularly for me, what stood out is just being able to take this deep dive into the funding sources and the finances of the colleges, and just implore you to stay in conversation with us as we move into budget season, but also as we're having conversations about enrollment. I think we've been talking more as a board in different spaces about how the university contributes to the state's workforce challenges, and how we bring really innovative and neat things to the table, and that was really evident today. So thank you.
Great. Thank you, Regent Farnsworth. And lastly, I'll turn to Regent Johnson.
Yeah. Thank you, and thank you for the presentations for all of you. So this is a special committee meeting of this special committee on healthcare, and I've been involved in this as vice chair along with Penny Wheeler and others. I think that as we heard these presentations, that we as a board ought to consider that we were constituted this committee to address certain important issues, and we're doing that now, and there'll come a time when we're kind of beyond and through some of those things. But I think we should give serious consideration to continuing the work of this committee, and that perhaps the next thing that we look at should be the healthcare workforce and what we can do working together, we as a board, you as the deans of these schools, and working with legislators, every other constituency within our state and beyond, to look at this and see if we can't work together to get better funding for all of these schools. The need is great, and I think that we should consider doing that.
I'll second that.
Thank you.
Great. And I'm seeing no further questions. Does anybody have, in our last minute and a half here, any further questions? Well, with that, I will thank you profusely for all that you do, all that you lead, all that you bring to the state and globally and beyond. And we have a much better understanding because of your time here with us today. I appreciate you. Thank you. Oh, and I will adjourn the meeting without breaking the gavel. Meeting adjourned. Thank you.
You're so good. You're so natural.
Thanks, Jason.
But your question